Namaskar. Hi friends, welcome on our channel. Today we will discuss and demonstrate how to do genital biopsy from bone. This video is intended for healthcare professionals only. Biopsy of a bone tumor with soft tissue component can be done from a soft tissue component also with soft tissue biopsy gun. In this video we will understand how to do biopsy from a bone with Jamshedi needle. Principles of biopsy remains the same for both, but technical steps differ. Technical steps for soft tissue biopsy will be covered in subsequent video. We will divide this video in three parts. First, plan and approach. First, we need clinico-radiological diagnosis to plan biopsy. This was a 24-year-old male with left knee pain for 7 months, slowly increasing and swelling for 2 months. Clinico-radiological diagnosis was giant cell tumor of bone. Then we need to decide probable final procedure. In this case, as a medial part is uninvolved and there is already an extraosseous soft tissue component on lateral side, curettage, cementing and plating will be done from lateral approach, and this will be probable line of incision for definitive procedure. Biopsy incision must lie along this line. Usually shortest is the best approach as it is in this case, but sometimes like in this case of periacetabular chondrosarcoma, shortest and easiest approach is supraacetabular transgluteal approach, but is not the correct approach because it does not lie with the incision of internal hemipelvectomy. So you cannot island out biopsy scar and resect it at final procedure, which is must for oncological procedure. Approach through anterior inferior iliac spine, even though it will require CT guidance to avoid vessels and target it precisely, is the correct approach. This article by Patrick et al. Nicely describes specific approach for all bones. Another important point regarding approach is you should always go intramuscular and never intermuscular. Like for biopsy from proximal humerus, routine orthopedic approach for proximal humerus is through deltopectoral groove between deltoid and pectoralis major, but it's a wrong approach for biopsy because hematoma, if formed, can seep down through facial planes and can contaminate large area, which may be very difficult to resect during final procedure. Biopsy through anterior deltoid is the correct approach because hematoma, even if formed, will be contained by deltoid muscle, so always intramuscular, never intermuscular. Viable area of tumor should be targeted for biopsy. In our case, it is not much of a concern as all areas seems viable and homogeneous. But in a tumor like this, necrotic and cystic areas should be avoided and biopsy should be done from viable area of the tumor. Measuring a biopsy site from bony landmark helps targeting specific part of tumor and avoid going near the joint or normal bone. Take a blank paper and pen. Decide bony landmark on MRI, which is lateral joint line in this case. Put paper's edge at the bony landmark. Mark on the paper from where you want to enter the bone. Measure it on the scale given on the MRI. It's 4.5 cm as this whole scale is 5 cm. Same will be marked on limb. If skin over the tumor is involved, anyways it will be taken out during resection. So biopsy may be done from that area rather than breaching uninvolved skin. Do not touch surrounding uninvolved structure which you are not planning to take out at final procedure. Like in our case, needle should not go deep in uninvolved bone, which we are not planning to take out during curettage. We can measure a depth of involved bone on MRI and correlate it with marking on needle while doing biopsy. To understand it better, this is a case of soft tissue sarcoma. Throw off needle should not touch uninvolved periosteum of the bone or deeper muscle, which we are not planning to take out with tumor at final procedure. Before jumping to procedure, don't forget these two important things. Take proper consent and explain any kind of risk if anticipated, like common peroneal nerve palsy in proximal fibula tumor biopsy. Biopsy can create lot of anxiety amongst patient and relatives. Proper explanation regarding procedure will help executing biopsy well. If patient is not comfortable during procedure, we may not be able to obtain adequate material and we may have to repeat the biopsy. So if patient is apprehensive, very young or involved bone is deep like proximal femur, don't hesitate giving general anesthesia or keep anesthetist standby at least. These are the instruments that will be required. We will see parts of J needle and how it works. This is needle, this is knob, this is a trocar which has a beveled edge which will pierce the cortex. This is stellate. Trocar goes in needle at particular angle and in a slot, so it doesn't rotate within the needle. Knob is tightened over it. It helps giving pressure while doing rotatory movements. This is how needle is gripped. Stellate is used to extract the cores from needle. These are the 10 simple steps for biopsy, each having specific point to be noted. After painting and wrapping, first is giving local anesthesia. Perpendicular to the skin, needle directly touches periosteum. Needle is withdrawn while injecting the lignocaine to anesthetize the whole tract. Surrounding 1 cm of periosteum should be infiltrated to minimize the pain. Skin incision is given cutting skin and subcutaneous tissue. Flush the needle with heparinized saline to minimize the clot formation, and needle is assembled as shown previously. With steady rotatory movements, cortex is drilled with trocar. If cortex is too hard to be drilled with trocar, hand or power drill can be used to make a hole in cortex. Once give away filling comes, trocar is withdrawn and needle is advanced to drill the core from the bone. Once advanced enough, needle is moved sideways to break the core and needle is removed with negative suction applied with syringe. Trocar or stellate is inserted in the needle to retrieve the core in heparinized saline. Once hole in cortex is made, only needle is inserted in the same hole and direction is changed and cores are taken from the other part of the tumor. Direction of needle is changed only once needle is inside the same hole and not before that. Filter the heparinized saline with a gauze piece to see if enough material and cores are obtained or not. Usually 3 to 5 cores are adequate. Keeping 2 bowls of heparinized saline ready helps, as if after filtering from the first bowl material is inadequate, we can continue procedure without wasting time to make another one while patient is under general anesthesia. This is how cores look like. Put the cores in container with plain forceps to avoid crushing of cores. Material is sent in 10% formalin solution. Usually single suture is required. Give adequate pressure for 5 minutes to prevent hematoma. This is very much essential step. Biopsy in some case scenarios will have specific concern that we need to exercise. In case of pathological fracture, entry site and course that we take should be away from the fracture. Otherwise, course from the fracture callus can mislead diagnosis towards osteosarcoma. In case of cystic lesion, it will not have tissue inside the lesion. We have to scrape the wall while giving continuous negative suction with syringe to get the material. Collect that material in syringe and filter it with gauze piece. In case of tumor with very fluffy material, like sometimes in giant cell tumor of bone where material is not hard enough to drill a core, just do very gentle pistoning movement after piercing the cortex. Keep heparinized saline bowl underneath the needle to collect outpouring tissue. But before this, you really need to be sure of radiological diagnosis, and conventional methods should have failed to retrieve the core from the bone. When infection is also one of the differential, send material in sterile container also apart from 10% formalin solution. Never split the material to send to 2 different pathologists for 2 different opinions. Send all material to one pathologist only. If second opinion is needed, send slides and blocks to other pathologists. Because sarcoma are heterogeneous, means one part of it can be low grade and other part of it can be high grade within the same tumor. So one pathologist will report it low grade and other will report it high grade if material split and sent. So this will increase the confusion and nothing else. So never split the material. Post biopsy, give patient adequate analgesics. Keep patient non-weight bearing or give splint if needed, because bone was already weak by tumor. We have made a hole, so it has become even more fragile. Prevention of pathological fracture is utmost important. Read in between the lines means you need to understand what is not written. For example, in this report, procedure written is excision biopsy, but on cross examination, it is written that multiple tissue bits were received, which implies it was a piecemeal excision and not proper one piece excision with margin. Biopsy report is not your diagnosis. Diagnosis in orthopedic oncology is always a coherent picture formed by inputs from clinical, radiological, and pathological information. Seek expert opinion from the beginning. Biopsy is best done by final operating surgeon or at least under his or her guidance. This was a 25-year-old girl had knee pain for 3 months, went to an orthopedician. This was the X-ray and MRI, which were reported as benign bone tumor, query chondroblastoma, chondromyxoid fibroma, or osteomyelitis. Patient underwent curettage, bone grafting and plating based on this report without biopsy. HPR came out to be fibrous dysplasia, which was accepted, though radiology was not fitting into it. Patient had persistent pain. Orthopedician thought it should be because of implant impingement and implants were removed, but still pain persisted. 2 years after the primary surgery, this was the X-ray with increased lesion. This is when orthopedic oncologist was involved. He performed a biopsy, which was reported by musculoskeletal pathologist as an low-grade spindle cell sarcoma, which was fitting into clinical and radiological picture. Though clinician, radiologist and pathologist were agreeing with each other on diagnosis of fibrous dysplasia initially, only missing factor was expert opinion from the beginning, which ended up in multiple surgeries and inferior oncological and functional outcome. So please consider involving the expert from the beginning rather than at the end. Thank you.